symptoms and initiating the bowel activity is well documented and is part of the ATHAR protocol as well. Maybe use of certain prophylactic agents and start early oral intake as soon as possible. We know that the bladder is an extra peritoneal organ. Why do we have to open the peritoneal sac? We know why we have intestinal problems. It's because when you open the sac, either in men or women, they result in a small bowel being in a closed space with nice fluid in between, and their peristaltic movements is so coordinated. It's only because they are in that sac called peritoneal sac. When we violate that peritoneal sac by doing traditional radical cystectomy, which obviously opens up the peritoneum, the bowel flops into the pelvis, they get stick to each other, and their movements is hampered, and it often results in development of intestinal obstruction. In my case, for sure. ERAS protocol is one way, as I mentioned, that you take your patient through the enhanced recovery pathway, and that can really improve. And this is now coming up not only for radical cystectomy, radical prostatectomy, but also for kidney cancer surgeries. So this is the anatomy. As you can see, that the green line is your peritoneal reflection over the dome of the bladder, and the rest of the prostate bladder that comes out during this procedure is all extraperitoneal. So why don't we try and do this procedure extraperitoneally and see if that can improve the outcome? So the way I do extraperitoneal cystectomy is that we start off with a standard lymph node section, which means that you dissect all the lymph nodes from the angle of RCL down to the lymph node of Clockwig. Caudally, then operate the fossa, the genitofemoral nerve laterally. And after this procedure, the next thing is that you take care of the uterus. The superior pedicle of the bladder. So the superior vesical pedicle of the bladder is next. And after that, we move on to the ureters. The ureters are divided, and by dividing the ureter and taking care of the pedicle, we have a relatively mobile bladder. The next step is to do what we do during the radical prostatectomy. So that you forget about the rest of the bladder, you go down into the pelvis, open up the endopelvic fascia. Once you open up the endopelvic fascia and take care of the puboprostatic ligament, you can see that in the middle picture, the puboprostatic ligament here. Followed by the dorsal complex, which is one of the major causes of morbidity and need for transfusion. We know that transfusion not only increases the morbidity, acute morbidity, but is also somehow related to poor oncological outcome in these patients. So this is the same steps that you do in an open standard radical prostatectomy. So once you've done that, you have the prostatic apex in front of you, and you can do either nerve sparing or non-nerve sparing, depending upon in radical cystectomy, most of the time, nerve sparing procedures can be done. In prostate, you need to be careful, depending upon the cancer and its location. If you're doing an orthoscopic bladder, it's really preferable to do a nerve sparing radical cystectomy. Once that is done, you can see that this is the apex of the prostate here. This is the urethra at the apex. The next thing is we divide the apex of the prostate, the urethra at the apex of the prostate. And then you start off with a section in retrograde fashion rather than the antegrade fashion that we do in hospital medical society. So this is essentially what you do. And it's important to remember that when you lift off the prostate, you start your dissection in the posterior plane, the adenomylous fascia is really an extension of the peritoneum. And if you don't divide this adenomylous fascia, you won't be able to approach and lift this prostate along with the bladder. So this is the next step. One of the advantage of this is that it significantly decreases the chances of rectal injury because the rectum is right in front of you once you lift the top of the rectal the aneurysm issue. The prostatic pedicle is next, obviously, and once you have taken care of the prostatic pedicle, your prostate is really lifted up, and you go in the plane between the bladder and the rectum. This is another area of importance because this area is have all the autonomic nerves passing in the midline. If you are careful, you probably can preserve those autonomic nerves that will also help in erectile as well as continence. So, as you can see in this picture, this is the apex of the prostate, the urethral catheter. This is the bladder, and we can just lift it up all the way. And you keep moving in this way. And you can keep moving. The most difficult part that I find of this way of doing cystectomy is to find the right plane between the reflection of peritoneum on the dome of the bladder and avoiding any inadvertent injury to the bladder or to the bowel. So this is one important area that you need to be a little careful. And if you do this step well, you probably will be just making a little hole in the peritoneum. This is one of the last steps when the bladder is completely lifted off, and you are dissecting it off from the dome of the bladder to the peritoneal side.
ठीक है ये तो यूज़ कर रहे हैं इसमें पहले में सिर्फ कटिंग होती तो कोटिंग कॉम्बिनेशन कटिंग आ रही ज़्यादा ये तो सजी में भी बड़ा अच्छा था
Anterior tumor, the dome of bladder tumor, probably would be better off doing the classical cystectomy rather than this. And this is a specimen with the prostate here, the bladder, all the, and we're taking a bit of a peritoneal. So now we have this intact peritoneum with just a little hole here in the peritoneum, which can be used to deliver your small bowel for reconstruction during the urine diversion. Both the ileal conduit and orthopedic bladder can be done in this fashion. The only difficulty is sometimes to identify the UC conjunction so that you take the right segment of the bowel out and do the diversion. So this is how it looks like with an intact peritoneal sac. My residents really love this procedure because most of the cystectomy patients are sitting here smiling. Is able to go home in 4 days time, something that we are not used to. We're used to something like 5 days, 7 days, 10 days, even 2 weeks, patients staying with the ILs. However, definitely this is something which is not. So this is small little window which is subsequently closed loosely, not to strangulate, and the rest of the reconstructions, how you do it. So this patient had a conduit. So cystectomy, obviously we have robots now, which significantly increases the morbidity of this procedure. We have so many protocols available to decrease the morbidity. The whole idea is to achieve that end effect, which is why the procedure is done, is to achieve the best oncological outcome. So you have to have negative surgical margins, we retrieve enough lymph nodes, we have good discussion on urothelial cancer and lymphadenectomy in the morning. There should not be any recurrence within 12 months of surgery, absence of high-grade complication within 90 days. So we achieve this pentafactor, however you do it, it doesn't matter. But in my personal experience, extraperitoneal radical cystectomy is a much more stable procedure than this. Thank you very much for your attention.
Thank you very much, Professor. Any questions?
Very nice. And it's really a problem that is elaborated ideas after the cystectomy and these transplant procedures. I just wondered when you're being in the ideal conduit, so you take the surgery has to come out, the baby has to come out from the conduit.
So it's the password 2142
I understand how that narrow window that is there, which is now the recently in the ideal conduit. Do you think